Can you go to the next slide? All right, next slide. Maybe I can run it.
Sorry, I'm having some difficulties moving to the next slide.
Maybe I can try to share mine. Let me see if I can share mine. Can you see my slides? Can you see my slides now?
Yes. Please go ahead.
Perfect. And let me just
Yeah.
go ahead. There we go. Perfect. I have the only disclosures I have for this talk is I have grants to support this music, this talk. This is our hospital here, Shriners and UC Davis, where we made about 900 burns per year. And if everyone can mute, that'd be great. So I want to talk about burn resuscitation, which is inconsistent throughout the world, and there are different practices, and we feel it's inadequate, so we need to do a better job. So I want to discuss principles of resuscitation and compare crystalloids versus colloids for burn resuscitation. And I've published one study, and we have a protocol going on that can help you with resuscitation. So I start with some basics in that 60% of the body is made of water. 40% of that's made of intravascular water inside the cell, intracellular water. And then extracellular water is 20%. And if you look at how water flows, it flows freely between the intracellular space and the interstitial space. But what keeps water inside our blood vessels is the protein. And that's the important part for burns. So the body will compensate for hypovolemia. You can lose up to 40% of your intravascular volume with no trauma and still do okay, 30% with trauma and still maintain a blood pressure. So that's important to remember. And we teach that we need to treat people with 20 milligrams per kilogram bolus if they're hypotensive. And if you look at the intravascular volume for a 60 kilo person, that ends up being just about 1/3 of the intravascular volume, and the same for a baby. So that's why we came up with that number of 20 milliliters per kilogram bolus if someone is hypotensive. But if you have ongoing losses, like in a burn patient, you need to place a Foley catheter and monitor urine output, and that helps us monitor. You want to have a target of 0.5 milliliter per kilogram per hour for an adult and 1 milliliter per kilogram per hour for a child less than 30 kilograms. So the classic teaching is that if you lose a liter of blood from somebody or take a liter of blood from somebody, the best thing to give back is whole blood. But if you don't have that whole blood, you use someone else's blood, and it will stay intravascular because it has proteins, and you'll need to give 1 liter back. The same is true for albumin or fresh frozen plasma or any oncotic fluid, that protein keeps the fluid inside the intravascular space. However, if you use an isotonic crystalloids like lactated ringers, all the water electrolytes goes into the interstitial space. So you need to have 3 to 4 liters to replace 1 liter of blood loss. And if you give free water, you need a huge amount, 12 liters, and that's a problem. Now, this is how I think of burn resuscitation. If you think of the body as a bucket and the bucket is what's inside the blood vessels, that's your intravascular space. You take a little water in, you let a little water out. And that water, basically nutrients go from the intravascular space to the cells and back and forth. And what happens with burn shock or any kind of inflammatory response is the capillaries open up and water and protein and electrolytes all flow out. What the body does is make that intravascular space smaller, and that intravascular space being smaller basically is made small by the release of epinephrine, norepinephrine, and vasoconstriction. So you maintain perfusion to the brain and heart, and the last thing to go is your brain, and people will die of hypovolemic shock while talking to you. Now, the goal of resuscitation is to pour the fluid in fast enough to keep the kidneys happy, or in other words, maintain a urine output. That's your goal. But people think sometimes if you put more than that in and you have more than the calculated urine output, that's good. But in actuality, that's a bad problem because you cause a lot of the excessive complications of over resuscitation. And then you get compartment syndromes, you get respiratory problems, cardiac failure. So you don't want to over resuscitate. You don't want to under resuscitate. We actually know a lot of the pathophysiology, what happens, what causes the leak from capillaries. Histamines, serotonins, bradykinin, leukotrienes, they increase the permeability. And you can't block one because there's so many activators that they all basically compensate for each other. So try to block a histamine, for instance, and it won't prevent the edema. We actually know the molecular biology, what happens with capillary leaks. There's three things that bind the endothelial cells together. There's the tight junction, which you can't change. There's the gap junction, which doesn't change, but the adherence junction is what opens the gate and allows fluid to leak out between the cells. And actually, it turns out that that molecule is connected to actin and myosin, and through signaling, through VEGF or histamine or other receptors, that actin and myosin pulls open the gap between the endothelial cells to allow for the capillary leak, water, electrolytes, and protein that comes out. And that ends up causing what all the leak is that happens with a burn patient. And there's the Starling's law that there's related to not only the hydraulic pressure, but hydrostatic pressure, but also the oncotic pressure. And the oncotic pressure is where we have the problem when we lose albumin, and we'll talk about that in a minute. That's the classic Starling principle. It's related to those two components, the hydrostatic pressure and the oncotic pressure, both inside and outside of the blood vessels. But it turns out it's more complicated than that. There's a layer of the endothelial cells called the glycocalyx, which actually acts as a permeable barrier. And so it maintains that intravascular space. So it's more complicated than we thought it used to be. And so it turns out that if you have a good glycocalyx, that the perfusion ends up being controlled. And when that gets damaged, as in a burn, the leak is much greater. So you have to have a revised Starling principle, and that's important to know. It turns out that there are a lot of things that involve with fluid shifts between the intravascular space and out in the interstitial space. There's between the cells, there's some transportation through the cells, and lymphatic resorption is also real important. It turns out that our lymphatic system has a great capacity to resorb a lot of the fluids that causes the edema after trauma, and it's incredible how fast it goes. The problem is that with burns, you get destruction of that lymphatic flow, so you don't tend to resorb the fluid as fast as you should. So those are some of the problems we see. And as we talked about with burn shock pathophysiology, you get extensive release of these mediators. And at the burn site, the proteins also leak out. So as you have proteins that leak out, the oncotic pressure outside the intravascular space actually increases water, or pulls water outside. And then you get damage to the collagen outside, and that breaks into small particles, which also pull some of that water out. And that's why we have such huge leak through the blood vessels that happens, and it peaks about 8 hours and it persists about 48 hours. But it turns out that capillary leak tends to shut down outside of the burn areas quicker than at the burn site itself. So it's not as bad. It lasts only about 6 to 12 hours. And it turns out we get such low albumin levels that the oncotic pressure inside the blood vessels gets so low that you get an ongoing leak. And so The big question is, how much should we use albumin in resuscitation? A lot of the classic teaching was that you shouldn't use it, but it turns out that it may be important. We don't know the lymphatic resorption, but clearly it's important, but we can't really treat that at this point. So what are our problems with burn resuscitation? Well, we have no agreed upon standard formula. You know, people talk about crystalloids versus colloids. That debate's been ongoing for decades. Should we use hypertonic solutions? And the problem's been stated by Dr. Pruitt years ago is fluid creep, that we tend to over-resuscitate, and that leads to the complications of compartment syndromes, as I mentioned before. So the endpoints, we just don't know what the endpoints are for fluid resuscitation in a burn. So if you give too much fluid or too little, there's problems. If you don't give enough, people die, or they go into renal failure, or you increase the burn depth because you don't perfuse the burn itself. If you give too much fluid, you get fluid creep. Again, I've mentioned this before. You don't respond to increased fluid output or urine output, you get compartment syndrome, lung injury, cardiac failure, and increased burn depth also. So why do we have a problem with burn resuscitation? Our formulas just aren't adequate. People follow them without really thinking about what's going on with the burn patient. There are a lot of things that change the depth that the resuscitation needs, the depth of the injury, associated injuries, delay in resuscitation, all can increase your fluid requirements. And then there are people who just don't respond when the urine output is really high. They just don't decrease the fluids fast enough. And we do know that our oncotic pressure drops too low, especially that increased leak, and our albumin levels get down to about 0.7, 0.6, where normal is 3.5 to 5. And it turns out urine output's not a great indicator of how well we're doing. And if you give opioids cause vasodilation, so you get increased fluid, you give fluids to kind of compensate for that hypotension. And it turns out with ventilators, David Mackey demonstrated that the increased thoracic pressure from a ventilator will decrease the venous return, so you have to give more fluids. So that causes a problem. So there are a lot of issues related to fluid resuscitation that we were dealing with. So how do you do better? Well, you can improve the responsiveness to urine output, have good staff, have protocols for nurses and doctors. And there's also a computer-based system called the Navigator systems developed by Galveston and San Antonio. And it seems it might help. People have talked about using high dose vitamin C, but the studies so far show that it reduces the fluid requirements. We don't know what it does, but it looks like it may be an osmotic diuretic. And I've been told by the people who really use it that you have to give fluids at the end, or else you may have hypotension. And we found in a study at our burn center that we had increased renal failure because you over diurese the patients. They can cause inadequate fluids. So I'm going to talk a lot about the debate between crystalloid and colloid. That debate's been going on for decades, and it goes back and forth. Initially in the early 60s, colloids were favored. Then we decided that crystalloids were the only way to go decades later. And now it seems like colloids have returned. So we need to know whether we should add colloids to the fluid resuscitation in burns. Well, what are the bad sides of using colloid? Well, colloid leaks out to a great extent. And so you have to give more than what's lost to make up, since all the crystalloids that go into the intravascular space also leak into the interstitial space. So you need more fluids, and that may contribute to fluid creep. It may not be a problem for small burns, but for big burns, it may be a big problem. As we said, it just, as I showed before, it just pours out. There's nothing to keep it intravascular. But the good things that crystallize work most of the time. You know, most of the time we can tolerate the extra fluid, especially in the small burns. It's cheaper, it's lower risk, it's easy to store, it's readily available, and it is the first line of treatment. But what about colloids? What's the problem with colloids? Well, they're more expensive. There is a lot of concerns about risk of transmission of infections like viruses. That seems to be better. And people talked about why give colloids if it's leaking out through the holes between the capillaries? You're just going to waste it as it goes out, at least at the early stages, and it acts as an osmotic sponge. As we stated earlier, in the unburned sites, this tends to close earlier. The capillary leak is less severe, so maybe giving some colloid later on, it may be beneficial. And we know that they get really, really low albumin levels. And as we stated, you need some oncotic pressure inside the vessels in order to keep the fluid inside. You don't need as much fluid if you just give a colloid typically. And again, we talked about the capillary leak closing earlier. And in our experience, it seems to work. So we'll talk about that. And as I said, the blue represents the proteins inside the intravascular space. That's the albumin, and it keeps that water in. So let's talk about the studies related to colloid and resuscitation. Now, first of all, hydroxyethyl starch solutions have been around for a long time, but there are now excellent studies that show that they should not be used for resuscitation for burns, for anybody, and they've shown increased renal failure, increased deaths. So do not use these starch solutions for burn resuscitation. Gelatins and dextrans should also not be used. What about fresh frozen plasma? There's been studies from about 3 decades ago, the Haifa formula from Israel, the Slater formula from Pittsburgh, Pennsylvania. They seem to work, but the cost of fresh frozen plasma is pretty high. There's risk for transfusion-related acute lung injury and infectious transfers. And there are actually ongoing trials right now to look at FFP, fresh frozen plasma versus crystalloid, and we'll see what they show. And I'm going to talk a lot about albumin. Should you give albumin or not? It makes sense that as your albumin gets super low, you should probably replace it to keep that fluid intravascular. Studies also show that it protects the endothelial glycocalyx, so it may protect the endothelial cells from damage. So that's another reason why you should use it. Well, what really stopped everything was in 1998. There was a Cochrane review looking at colloid versus crystalloids, all kinds of critically ill patients. And what they found in that study way back then was that there was increased risk for death by giving albumin. And basically that review stopped the use of all albumin in trauma, burns, and sepsis. And so people said, all right, you shouldn't use it. And so everyone switched to crystalloids at that point. But then again, Dr. Pruitt mentioned we're drowning our burn patients. Maybe we need to change things now. So they did a lot more studies. In 2012, they did another colloid versus crystalloid study in critically ill patients. And what they found was that, hey, they look at 24 trials. These were not burn trials. They were just sepsis trials, big critical trials in critically ill patients. And what they found with over almost 10,000 patients was really no difference in survival. So maybe colloids weren't bad after all. So here's some of these studies they looked at. One was the SAFE trial, and basically looked at almost 7,000 patients, ICU patients, not burn patients, and they showed no difference in mortality. Here's some other trials. The EARS trial, no mortality difference. The Albios trial, no mortality increase. 2014, a meta-analysis showed no risk of death, increased risk, but maybe even a shift towards maybe it may be protective. So people start saying, wow, maybe this does work. Okay, so let's talk about burns. What do we talk about in burn patients? Well, there's 2 approaches. One, you could start albumin right from scratch, and the idea behind that is, well, just maintain that oncotic pressure. it doesn't make sense because at least initially a lot of that albumin would leak out. The other thing is like just use albumin as a rescue. If you're going way too fast with the crystalloid, maybe add some albumin to see if it would slow down your resuscitative rate. So here's some of the trials. As early as 1975, Racinos, not very many patients, did albumin versus lactated ringers. And you know what they found was that it seemed like albumin reduced the fluid needs. So maybe we should use albumin. Again, 3.4 versus 5.2 for kids, 2.0 versus 2.9 milliliters per kilogram per percent burn at 24 hours. Yeah, maybe it seemed to work. And there's only one case of renal failure, and that was in the LR group. So suggesting that albumin might be worthwhile. Jelenko, not very many patients, and he had multiple different patients, but he also had hypertonic saline, but again, suggested that albumin might be beneficial. Then Dr. Goodwin, 1983, did LR versus LR from plus 2.5% albumin, and he showed less fluids, but he looked at lung water, and he showed that with albumin, you had increased lung water, suggesting that you might damage the lungs if you gave albumin. He also showed improved cardiac function, and he showed the black dots here showed that increased water. So maybe it's bad for the lungs. So people stopped using albumin again. There's a later study by Cooper, LR plus 5% albumin. And he found less fluid with albumin, but it wasn't statistically significantly different. All right, well, what about rescuing the patient with albumin? Well, the concept again is that the capillary leak closes unburned patients at 6 to 12 hours. So, it drops to really low levels, but maybe if you're really out of control, give some albumin to slow down how much fluid you have to give. It makes sense. So a lot of these studies started in Utah, Salt Lake City, Dr. Saffel and his group. And Dr. Cochran, 2007, looked at what they did with 100 patients. And they had a protocol that if you were 2 times the Parkland formula, in other words, if you're going at 8 milliliters per kilogram per percent burn rate, you should add some albumin. They added 5% albumin plus 1/3 plus 2/3 lactated ringers. And they found that the albumin group were the sicker patients. They had more inhalation injury, higher lactates, longer resuscitation, higher volumes, but no difference mortality. And maybe it looked like it might have been protective to give albumin. And it's from the military had a protocol. If they were transferring soldiers back from the Middle East and patients were above the target, 6 milliliters per kilogram per percent burn, they gave 5% albumin. They also gave pressors if they're a problem, and they showed a reduction in abdominal compartment syndrome and mortality. Another group also looked here, Dulhunty. Well, maybe they reduced the problem. It's hard to study, hard to interpret this study. And then a big study from Salt Lake City, Utah. They looked at adults. And again, nurse-driven protocol. And if they're out of control, they gave albumin. And you can see by this graph, the ones that they gave albumin were really going crazy with the amount of crystalloids. And they gave albumin, boom, you can see a big drop and how much fluids they required. And this graph is a little bit tricky, but what it shows is this central line is where they gave albumin. They started albumin. This is the time before albumin. You can see how the rate went way up. And if you gave albumin, boom, it reduced fluid requirements. Feroclus, another Utah, this is the same study, but in children, they showed the same thing. You gave albumin, boom, it dropped down. Park, in a different study from Michigan, again, what they showed, they had 2 protocols before and after, where if they're out of control, again, greater than 6 milliliters per kilogram per percent burn, 24 hours, they gave albumin, and they showed a reduction in vasopressin and pressors, and seemed to help. He also showed improved mortality, vent days, abdominal compartment syndrome, pneumonias, so it seemed like it might work. Now there's a couple of meta-analyses that show, again, no difference in mortality, no, maybe an improvement in compartment syndromes, no difference in respiratory complications, so you don't have to worry about hurting the patient's lungs, and no change in renal function, maybe even improvement. Another one, Belgiaic, same thing. Here's like no difference in mortality, improvement in resuscitation fluids. And it was challenged though by another guy who took out one study and showed that maybe there was increased mortality, but it wasn't quite significant. But these are the problems. And I actually did a survey that we published about 10 years ago. And I asked people, by the way, do you use albumin? And half of the people said, yeah, oh yeah, we gave albumin, patients were out of control. So that's what the practice was. And clearly when we talked in 2016, talked to the burn surgeons from around the United States, they gave albumin if things weren't going well. So Dr. Cartado and I started a study several years ago. It's called the ABRUPT study, Acute Burn Resuscitation Prospective Multicenter Observational Trial. We had a grant from the Department of Defense and we got $2 million to study this. It finished in 2021. These are all the centers from North America, 2 from Canada and several from the United States. And basically all we did was observe what people did in 20 burn centers over a 2-year period. What did you do for resuscitation? It was in burns greater than 20%. And what all it was is that you had 2 choices. You could use crystalloid or albumin. You couldn't use anything else. And you had to follow the patient for 48 hours without surgery. And we finished it early. And out of 400 patients, we were able to evaluate 379. So we had a pretty good evaluable group. And these are kind of the statistics, age about 46. These had to be adults. You can see that in the United States, people are bigger, BMI is fairly good, pretty good size burn, 35%, full thickness, 14.6%, and a lot of inhalation injury. And overall, we were able to get patients into the study almost around 3 hours after their burn. They had fairly high SOFA scores. They had fairly high lactates and base deficits. This shows the size of the burns that were studied in the patients. And clearly there's a lot more smaller burns in our country. As you go down, there are very few big burns. And this is the important graph. And what it shows is that 2/3 of the patients had received colloid. That was the practice. There's only 1/3 that just received pure crystalloid. There's really no other difference other than those patients had bigger burns that got colloids, bigger full thickness burns, had more inhalation injury, more vasopressor use, higher SOFA scores. It seemed like then that the colloid patients were the ones with the worst burns. And this is more the urine output. They had a pretty good target. The dark lines show the difference in volume here. Here is the crystalloid volume, a lot more in the colloid group. And they were good with urine output. So they hit the target there. And so clearly we showed by multiple logistic regression analysis that was those who got albumin had a larger burns, they're older and sicker. And this is more at 48 hours. And this is probably my favorite slide, is that there's a huge debate about what should be the target for resuscitation. Well, this is what we found. On the average, it was above the Parkland formula for 24 hours. And those who got crystalloid were right about Parkland formula. But again, these were fairly big burns. I think Parkland's smaller numbers for the smaller burns is okay. And the colloids pretty high in amount. So the Parkland formula seems pretty close for these big burns. And this shows the time of when we started albumin. Some got it very early, but most of them got it around 12 hours. So it seems like most of them got it at the point where they're worried about, hey, our rate's going really out of control. And this shows the colloid versus crystalloid group. And you can see the colloid group is the top line. And when they got the colloid, it dropped precipitously. And this is divided into the top line is those who got it earlier, were they're really out of control. If the rate was going really high with crystalloid, they quickly gave colloid. And if they weren't too bad, they gave it later, suggesting again that when resuscitation was out of control with crystalloid, the practice in the United States is to give colloid. And I showed you this picture from before from Utah. It's almost identical to what we see in their study. So our interpretation is that caregivers monitor the I to O ratio, the in and out ratio, and when providing crystalloids. And if it's not too high, they kept giving crystalloids. In other words, things going fine with crystalloids, who cares? But if the crystalloid rate was way too high, albumin started earlier. So that was the point. And we did the same graph. This is the time we gave albumin. You could see up to that point, fluids were getting crazy. If you give albumin, boom, right afterwards, it dropped precipitously. The fluid requirements go way down based on urine output, just like we saw at the Utah study. Again, showing the amounts, we gave a lot more for the sicker patients. And so we also asked the question, does the ventilator affect fluid needs? And what we found was that, yeah, if you're on a ventilator, you're going to need more fluids because of that increased intrathoracic pressure. And so it supported the idea of Mackey that if you're on ventilator, you're always going to need more fluids for resuscitation. These just show different points. This is the blood pressure. You give the albumin, it seems to improve your blood pressure, your heart rate improves, and the outcomes are different. Those who got colloid, they had a lower survival rate because they're sicker and worse burns. They had more ventilators, longer ventilation duration. As a matter of fact, the crystalloid groups were not very sick at all. Length of stay was much longer than albumin. And so clearly, if you have a worse burn, you're more likely to get albumin. And only the ones who got crystalloid, the ones who got fasciotomies, abdominal compartment syndrome, although there was only 2, and only much more patients required renal replacement therapy if they received albumin. So again, sicker patients will be treated with albumin. And we asked the question, when does resuscitation end? And we based resuscitation end on a formula that I learned from Dr. Warden in Cincinnati, was that once your fluid rate got down to your daily fluid requirements, plus a formula that calculated your evaporative needs, you're resuscitated. And you could see that people finish resuscitation, especially in the colloid group, as late as 44 hours. So people used to think you were done at 24 hours. If you're superficial burn, you're close to that, but not with the bad burns. It can take longer than 24 hours. These are the key points of this study, that caregivers in the United States and Canada use albumin for acute burn resuscitation, 2/3 of their patients. Albumin tends to be used in patients that are older, larger, deeper burns, more severe organ failure. Our target rate of fluids still seem to be around the Portland formula. Albumin is dictated by the trajectory of fluids given. When too much crystalloids are given, people give albumin, and it seems to work to reduce fluid requirements. This is now published in Annals of Surgery. You can get it. It just came out in print a couple months ago, and you can read all this. And so we actually asked for an extension because originally I wanted to do the prospective randomized trial. And then the Department of Defense said, no, I don't want you to do that. I want you to do the observation trial first. So we did. And then we got the second grant. We learned some things from the first grant in that we probably shouldn't include small burns. So what we learned from the study was that for the prospective randomized trial, we need bigger burns because it probably doesn't matter in small burns. So burns greater than 25%, greater than 20% full thickness, and they had to be over 18 and admitted less than 12 hours. And we now have enrolled 69 patients in the prospective randomized trial. Hopefully we will show that albumin is ongoing. We actually did an interim analysis of the first 59 patients, and even numbers, no difference mortality, but we have had almost a 30% crossover rate from people giving albumin when they are randomized to the crystalloid group because their crystalloids seem to be too fast. So we're going to keep going with the study, but it sounds like the crossover rate is too high, and we'll probably prove that for burns that are large and deep, albumin should be part of the resuscitation study. So in conclusion, the study suggests that albumin maybe improve resuscitation, probably for the big burns, that Abrupt2 should find the answer, that we're probably going to end up with a new resuscitation formula in the near future. I have many thanks to many people. Dr. Cartetto is my co-investigator on these studies. Sandy Taylor and Jeff Fine have been our statisticians. Katrina and Mary Beth are basically our research coordinators, and a lot of people, Dr. Palmieri, and Lori Palfalvi, have helped with the study. I greatly appreciate your invitation to speak to my colleagues. It would have been much more fun to visit you in person. I'm sorry I was a little bit late with starting. I actually had to drive to a friendly neighbor's house to get the internet so I could use it. But I appreciate your attention, and I'm happy to answer any questions at this time. So thank you very much.
Okay, thank you very much indeed, David. That was fabulous. I think we thoroughly enjoyed your presentation in the last 43 minutes. Thank you for the remarkable insights in fluid resuscitation, and then the seamless connection you tried to make with the pathophysiology of burns. I think the audience, on behalf of the NAPRAS president and Professor Ogbunaya, and of course all the senior faculty here, thank you very much indeed. We really appreciate this. So the jury is out, ladies and gentlemen. So if you have comments, questions, please indicate by show of hand, and then I'm sure he'll be happy to take your questions. Professor Ogbunaya, sir.
I don't have any question yet.
No, sir. I wasn't asking you a question, sir. I just wanted to be sure that that protocol was okay. The housekeeping.
Yes, you are doing very well.
All right. Thank you very much, sir. Yeah, David, maybe I'll just initiate the discussion. We have to see hands up, but kindly let me know. Okay, please go ahead. Thank you.
Okay, thank you. So thank you so much for the lecture. Actually, the aspect of albumin that you have brought out is quite interesting, because I can remember one of the ISBI conferences. I can't remember whether it was Edinburgh or in the one in Miami. There was a question on the use of albumin, and there was a big debate on whether or not to use albumin. And it's when we do our ward rounds and where I practice, it's a constant question that we ask about the use of albumin, whether we should use albumin or not in terms for burns. Now, the time for resuscitation, usually most of the formula you have usually for the first 24 hours. Now, if the resuscitation from extends up to 44 hours, then there should be, it's about time we have actually a formula for the second 24 hours, or what do you think? What are your thoughts on this?
So my feeling on resuscitation is that I know the formulas are designed for 24 hours. I don't think, my feeling as the resuscitation formulas are only for initiation, the start. Where do you start? Do you start at, and so in the Parkland formula, where they say after 8 hours, you cut it in half. Well, you don't really do that. You start with what the formula initiates the study with. And then after that, forget about the rest of the formula and you keep reducing your fluids based on the urine output. We're actually a big debate whether we have anything better than urine output for indicating resuscitation. But at this point, we do not have anything that's better. So yeah, I don't think you need a formula for the second 24 hours, but I think you need to just keep adjusting your fluids based on the patient's response. And if they're making adequate urine, you can keep on going down. We usually calculate a maintenance formula based on evaporative loss plus your daily fluid requirements. And then get to that point, then you can just stop and switch things over. And you can usually tell you're done with resuscitation and you can switch IV fluids from lactated ringers and albumin to maybe D5 half quarter normal saline or D5 half normal saline and do fine. So just use the formula for initiation of fluids. And if the Parkland's really high, you rapidly reduce it. And if you're not making urine, you increase it. So, and I think that's all you need to do.
Okay, thank you. Just to direct your presentation again towards some remarkable improvements in the evolution of bone resuscitation. I think for most parts of the low income settings, we will agree that there's been remarkable improvement in resuscitation, even though we've been using a lot of crystalloids. I think 10, 15 years ago, most patients will come to the hospital and hypovolemic shock, or shock will be the most devastating consequence, and then they'll pass on. And I think that's a global thing. So I think it's heartwarming to know that we've moved on from the assumption that poor resuscitation will lead to poor mortality within the first 48 hours. So even in settings where they don't have bone centers, they don't have critical care centers, you find out that just compliance or adherence to fluid formulas, and then of course, diligently monitoring input and output has led to remarkable income. So I think that part of the evolution in fluid resuscitation is extremely important. But I'd like you to put this in context as well. Most people also agree that the next key theme in resuscitation of the bone patient has to do with tangential bone excision. If you do resuscitation, and then of course you don't go ahead and do what the problem is, it means the natural history of the bone injury will also lead to not only mortality, but a prolonged hospital stay and a very, very poor outcome. So what's your take vis-a-vis on a scale, resuscitation versus bone wound excision for the bone patient in terms of resuscitation?
Well, I think we're believers in early excision. And if you have a big burn, you take them to the operating room and excise the burn, their fluid requirements go down extremely quickly. So I agree with you that early excision slows that process down, stops that inflammatory response. I think it's a good strategy. Now it's hard to always practice that and get things mobilized. But for instance, we have a patient come in on a Tuesday, we'll start resuscitation, but we'll probably take them to the operating room the next day. But if their fluid requirements are still high, excising the burn is really what makes a huge difference and slow that process down. We're big believers in early excision and grafting, but you have to have the resources. You have to have the blood. You have to have the team. So we'll have multiple surgeons excising different extremities at the same time. So that's something you have to do.
Okay, I think that's an excellent takeaway message for us. Dr. OK, can see your hand. Please go ahead with your questions or comment.
Hello, everyone. Thank you, Prof. David, for the lecture, especially making a great deal of understanding clear about the evolution of the pathophysiology to date. My question is regarding the use of colloids. I see that from the studies you shared with us, it appeared to be basically albumin. and I'm wondering if there's any alternative to albumin that that can be used. I ask this because of the great challenges that we have in the third world, getting albumin and blood products, and if there's anything that would serve as well, or at least nearly as well, that can be more easily sourced.
Yeah,
Thank
that's
you.
a very good question. In that, you know, I mentioned earlier, people use fresh frozen plasma, but that's that's probably more expensive, you know. And I know people are working on freeze dried plasma, but that also be expensive. I know some people have used hydroxyethyl starch, and I'm not sure if that's available for you guys. It might be an alternative, but there's certainly in those sepsis studies, there's increased renal failure, bleeding problems. So there aren't too many good alternatives, but I suppose if that's cheaper and you have no other alternative, that might be the alternative that you could use. But it's good to have a protein, and maybe at some point someone will create a frozen plasma that you could just add to like lactated ringers. But right now, I do not believe that's the case.
Okay, thank you very much. Great. Dr. Oiki, I thought I saw your hand. Please kindly go ahead. Okay, so he's still there. Yeah, one of the most significant indicator of mortality is inhalational injuries. Yeah, so I just like you to share experience with us, even though you mentioned it in the abrupt studies. The teaching has always been, of course, even if you're going to use crystalloids, for most patients, when they have severe burn injuries, and then of course you also have inhalational injury, that's almost an independent predictor of mortality. Yeah, so in the study, crystalloids versus colloids in patients who have inhalational injury, and we've seen in your abrupt study, there's a bias towards using it for more ill patients, obviously patients who have more inhalational injury. But is there any concrete conclusion per se that says, yep, if you have inhalational injury because of the requirement for more fluids, you will recommend colloids?
Yeah, I think that's another good question. It doesn't answer the study didn't answer the question per se, but clearly it's been known that two things: inhalation injury increases your fluid requirements. Second, that increases your mortality, as you say. I think the important thing with inhalation injury is to avoid over resuscitation. So in theory, it's probably worthwhile to say that if you have inhalation injury starting albumin, especially if you're not resuscitating well, it's probably in the long run going to be beneficial. We haven't proven it yet, but clearly we know that over resuscitation will make it a lot more difficult to deal with that patient.
Okay, thank you very much for that. Just one quick one before I call up Dr. Obiya de Solomon. Your endpoints of resuscitation, I think there's still a lot of debate around it. What do we use? Urine output is not so reliable. Right. So from your study, are you going to suggest anything? What's the line?
So the problem is that once you give all that extra fluid, after about 24, 48 hours, you start resorbing all that fluid through the lymphatics and things like that. And so your urine output picks up. And I teach that you can't rely on urine output for the next several days. The formula that we had, there is a formula based on, you can figure for evaporative loss that Glenn Warden taught us. It's somewhat complicated, but it's based on basically the burn plus the 25 times your body surface area, total body surface area, not the burn body surface area, gives you milliliters per hour. So you can calculate evaporative loss, and it's a very arbitrary number. And we've actually debated in many of our state of the science meetings, what should be the end point. You know, is it, because it seems like lactate doesn't come down for a while. Your hemoglobin stays high for several days before it kind of equilibrates. So you're right, we don't have good indicators, and that's why he came up with a number based on that Mr. Formula.
All right, thank you very much, host. Yeah, go ahead, please. Okay, so the takeaway message, David, is we should just continue to be diligent with urine output.
Keep diligent, and then once you get at about 20, I'd say at least by, I'd say 36 hours, 48 hours. If you're down to a fairly decent rate, I would just kind of keep it at that rate for then and just adjust it based on your laboratories, your BUN, your creatinine, those kind of things. So once you get 24, 48 hours, you can really slow it down and you'll be pretty safe.
All right, so I'll just read out one quick question from you from the chat box before Dr. Solomon takes this question. And David, this is for you. What fluid regimen will be recommended for a 28% superficial burns in a 35-year-old male patient in relation to colloid versus crystalloids?
I think superficial burns, you're pretty safe to go with crystalloid and that size burn. Most of the time, a healthy person can absorb that fluid and you probably be okay. And this is an incident where you may want to start at a slower rate, maybe use a 2 milliliters per kilogram per percent burn or a 3 milliliters per kilogram per percent burn. But a superficial burn, especially, they need less fluid. Deeper burns need more. So I would start slower in that kind of a burn.
Okay, Dr. Solomon, please go ahead. Thank you.
All right, thank you very much for the presentation. I want to really know what you have to say about the use of a Hemasil in place of albumin, especially in an environment where albumin is not readily available. Can we actually use Hemasil, which is one of the volume expanders, in place of that? Thank you.
To be honest with you, I do not know what Hemasil is, but if it's an oncotic fluid, I think it's probably worth, something worth using. And I'm not sure exactly what it is, but if it has some oncotic pressure enhancing activities, I think you might as well try it if you don't have albumin.
Okay, Professor Bona, it's 8 o'clock. How many more minutes do we have, please? Are we latitude till 8:30 or thereabout?
No, 8 o'clock is okay. Our time is actually, it's just to invite the president to give the vote of thanks, then we conclude.
Okay, then just one quick one before the president comes in. Your thoughts on blood transfusion for bone resuscitation. We talk mainly about fluid, crystalloid versus colloids, but in our setting, it will astonish you to know that we get total body surface area sometimes exceeding 50, 60 on a regular basis. And then of course, we know direct thermal injury to the blood vessels in the capillaries. Requirements for blood transfusion is key. What in your own experience is the relevance of blood transfusion in resuscitation of the bone patient?
So it's rare that we need to give blood unless there's some kind of bleeding somewhere. So almost never give blood. And then if you're going to give blood, the study by Dr. Palmieri clearly demonstrated that you should not give blood to a burn patient until their hemoglobin goes below 7.
All right, Dr. Mrs. Abekoyema, NAPRAS president, it's all yours. Thank you very much.
Thank you very much, Professor Abdul-Rashid Ibrahim, for the moderation. I'd like to thank David Greenhalgh for the beautiful presentation. I think this is something very relevant for us. Yes, low and middle income environment in which we are. For us to have good outcome of bone care, we need to know our onions when we do fluid resuscitation. So we appreciate this knowledge that you have shared with us. And this is to help in quality care improvement in our environment. Thank you very much for the time and for the beautiful presentation. We look forward to having some more sessions with you in varied ways. Thank you. And I'd like to thank everybody for attending the meeting, for making our time and for ways of improving bone care in our environment. I'd like to thank the Secretary of the Association, Dr. Ing, for the IT backup, and the Secretariat for a good job. Thank you so much. And you do have a good day. Thanks and bye.
Thank you very much. Thanks for the
Thank you.
invitation.
Thank you. Thank you very, very much. Thank you, Dr. Arnold, too. Thank you.
Thank you all.
Thank you very much. Thanks.
Yeah.
Thank you all.